only talk about this presidential debate for so often. So as this reprieve, we decided to bring our next guest in, Jonathan Wilcox, who is the co-founder and policy director of the Patients Rising and Patients Rising Now. Jonathan Wilcox, welcome to Big 550 KTRS.
Well, good morning, McGraw.
So you're going to be in St. Louis tonight for a conversation, is that right?
I'm in St. Louis yesterday. I'm in St. Louis today. I'll be in St. Louis tonight. The conversation we're having is really about patients and the epic threat to their access. Now, I think that could be a shock to a lot of people. It was a shock to me, too, to find out that patients with chronic diseases and serious diseases like cancer are under attack in the ways policy is designed that will limit their access to the medicines that they need and deserve. It's a debate that I think we need to be having, and one that I think you could, we're going to need to listen to for a lot more than 5 minutes at a time.
Sure. All right. So I thought all of those caps and those pre-existing conditions and the lifetime limits were gone thanks to the Affordable Care Act.
Well, we're in a very different place, and I think that that just simply never came to pass, and let me tell you why. We're having right now a broad national, conversation, even I think over-focus on simply cost. And healthcare costs are expensive. Medicines are expensive. I get that. But I'll tell you two things that have happened in this really robust back and forth. One, it has crowded out every other reform conversation we can be having. It's about insurance design, about regulatory reform, staying away from price controls, which never work anywhere else. And the second thing it's done is, by just saying, this is too expensive, this has got to be cut, what it's done, McGraw, is that it's unleashed the most profound anti-patient policies in a generation, even in the aftermath of what you said, the ACA, other attention on patients. What's happened is now patients are being looked at, to me, as commoditized drains on resources instead of a community of people who we know how to help and know how to treat and hopefully know how to save.
All right, Jonathan. So, for example, you're telling me that you have example after example of people who need life-saving drugs who can't get them because they've reached their limit?
Well, some people, a lot of people are being treated, but there are some people right now, people with serious diseases like cancer. Like right now tonight, last segment tonight, we're talking about non-small cell lung cancer that affects 200,000 people every year. An entity called ICER is here in St. Louis to evaluate what it says is going to bring down the price of medicine. But to me, all they're doing is putting caps, all they're doing is putting cuts, and all they're doing is putting the limits on what patients can get. They look upon them as too expensive to treat and too costly to save. And for us, the barn is on fire for patients because if we don't get access right, it won't matter what the price is. They simply won't be treated.
Explain that. What do you mean access right? Explain that.
Getting access right for patients is finding the best and most facilitated way to put the medicines that can help patients and treat them in their hands. Look, a lot of us think, I used to think, that healthcare went like this. A doctor and a specialist determined what was best for your course of treatment if you're seriously ill. And they determined what's best for course of treatment, this medicine, this therapy, and then you were able to get treated by it. That's not the kind of America that we're living in right now, and I think it's shocking to some people. There are now, I said, caps and barriers to access that are blocking patients from getting the treatments that they need because they're looked upon simply and only as too expensive. We have got to fix that.
Who's making that decision? Is it the insurance company? Is it Medicare? Is it Medicaid? Is it the federal government? Who's making that decision?
It is an assemblage of all this. Primarily, this is an insurance problem. Primarily, this is also a concern of the pharmacy benefit managers and the pharmacy system and even regulators in Washington. The fact is, it's all of them. And the entire healthcare system has got to get reoriented to where access comes first and we figure out the complications later. We're not having a conversation about regulatory reform. We're not having a conversation about why this is too expensive. We're not having a conversation about the best ways to improve insurance design and what you just mentioned, what we all expect. We're not talking about any of that. But in St. Louis, right now, and right now today, they're talking about only how much to cut, how much to limit, as if that will help the system. That is a death sentence for patients.
We'll get to that in a second. Recently, EpiPen was criticized for increasing the costs of their EpiPen. And so many people want to talk about, bringing the market economy to healthcare, which will bring down prices. Well, EpiPen shows that, I try and sell my product for as much as possible, and if I can get more money for it, great, right? If I got tickets to a World Series game and I can spend more money, spend more for it, great. But an EpiPen has different morals, has different issues to it. You have a kid who is, having some type of shock because he ate the wrong shellfish, and all of a sudden you don't have enough money. What type of community do we want to live in where we can charge the most amount of money for a drug? That's what you're talking about.
I say bring it on. I say fix EpiPen. I say fix that problem. Clearly, we saw major complications in how that's happening and major things that we did not know in community of patients that are not being served. But in addition to that, there is side by side the problem that we say of patients who are looked upon as too expensive to treat, honestly, and too costly to save. There are two. I brought patients here today who have non-small cell lung cancer, who are living 1, 2, 3, 4, multiple years beyond what used to be. If we limit what we can spend and invest in patients, we'll limit and spend what we invest in innovation, and that's the only way that anybody will be saved and treated and be able to go forward.
Okay.
By all means, let's fix EpiPen, but at the same time, we cannot limit what we are investing in a smart way and in the right way, not a careless way.
Okay, so
make the system more reliable.
Jonathan, so what's going on in St. Louis? Explain to people what's going on tonight.
What's going on in St. Louis for the second time is an entity which is located in Boston called ICER, a nonprofit called the Institute for Clinical and Economic Review. And what ICER does is they look upon one disease type at a time. When I was here months ago, they looked at a disease, blood cancer called multiple myeloma, which is somewhat rare. And then today they're looking at one for non-small cell lung cancer. What they do is they look at a drug, a medicine, and a therapy, and they say, well, today it costs this. And that looks upon as too expensive. So we will, our estimation, our math formula says that it ought to cost this. That is crazy. That is no way to treat patients with serious, chronic, and life-threatening diseases. It will only and simply limit their access to these medicines. We've got to do better than that.
So who are they meeting with here in St. Louis? Why is this meeting in St. Louis, and why is this Boston nonprofit coming to St. Louis?
Well, I've asked them the same thing. They, I think, are taking a somewhat regional approach to going around the country and doing these things where they feel comfortable. But my point is, in a lot of ways, they've taken it upon themselves. My major concern with this is not they have any special power, not that ICER has any special influence, but to me, I think they're attractive to the insurance industry and attractive to regulators in Washington, who I think are pretty interested in complicated math formulas that can limit patient access because they think it may reduce costs of the system. But to me, whatever savings they think they're going to get are the most expensive money we ever pocketed, because by any objective measure, fewer patients will get treated, and therefore those costs will skyrocket, and in the realm of human capital, we will be losing everything.
Jonathan, you're clearly ringing the bell here, and you want you're making noise. You're going around town. You're talking about this. What do you want the people of St. Louis to know, and what do you want them to do about tonight's meeting?
Look, the meeting is this morning and today and in the afternoon at UMSL. Here's what I want at St. Louis. I want the people of St. Louis and everywhere to know and understand. There is an enormous, I think even unintentional, anti-patient wave of policies that are coming down from Washington, land here in St. Louis, and everywhere else in between, and up and down the West Coast and all across America. We've simply got to think larger and better than how we just have price controls, how we limit treatment protocols, and finally, how we understand what's happening. I think a lot of people just simply don't believe and cannot comprehend that the kind of barriers to access between patients who are seriously ill and have chronic diseases can actually exist. But right now, it is happening in this country. But we have the ability to change it. Not by condemning anybody and calling names. We have the ability to demand a deeper conversation and a better dialogue that will include all the concerns, including price, and all the concerns to make this thing better. But if we just start cutting from the top, my Lord, patients will absolutely be devastated.
Well, I mean, this sort of is a larger question. Is so many people are complaining about the Affordable Care Act and that premiums are going up. My deductible's going up. Heaven forbid it's going up 10, 15, 20% at some places. Some of these insurance companies are getting out of the exchanges. And elected officials are talking about how we need to bring those prices down, and I've often been criticized for saying, my cable bill's going up, but the government really has no say in that. So if you either want the government involved in healthcare or you want the government out of healthcare, but you can't have it both ways.
Well, there are better ways to do this. Look, I mean, we need to have. I've always believed where market forces can help, then they need to be unleashed. I think we have serious problems in how these entities are regulated. I have serious concerns about how things are brought to market, the expansion of options. These things have to be tried to and in addition before we just start cutting. My real challenge, we lay it out in front of me. Fundamentally, the point is this ICER as a think tank has just stopped thinking. They have no ideas how to make the system better. They have no ideas how to fix the regulatory system. They have no ideas how to improve insurance. They're just cutting from the top. We cannot throw up our hands and just say, you know what, it's too big, it's too complicated, we just can't handle it. That's what's happening right now.
Jonathan, is there a website where people can find out more about this?
Go to ours, patientsrising.org, P-A-T-I-N-T-S, plural rising.org, and also ICERWatch.org.
ICER, you said, is a nonprofit agency out of Boston. Doesn't sound you're not portraying a typical nonprofit that you would think would be dedicated towards.
It is not, and look, you know, I mean, obviously, I'm very, very critical of ICER, and they're very touchy and sensitive about me questioning their motives. Look, I'm just going to lay it at the bottom line. I'm not saying that they're bad people. I'm saying that their ideas are wrong. They are dead wrong, and we've got to think bigger than just how we sort of casually and mathematically manage a system which people's lives are at stake, and we know how to care. We can do better than Mylan. We can do better than ICER, but we won't, and we just accept the way things are going.
Yeah. Are you having any group discussions tonight at all? Are you asking for anybody to meet you or show up anywhere?
Last night, and I'll be back here in January. Last night we had our Voices of Value Speak Up conference, in which we brought patients and healthcare economists, clinicians, and the audience to talk about what's happening and what's facing patients. And I just want to tell you, you wouldn't believe where patients come to us who have non-small cell lung cancer, which is years ago was a total, absolute death sentence, and they are living and they are thriving. They've come here from around the country, from Syracuse, New York to St. Louis, from L.A. to St. Louis, from McLean, Virginia to St. Louis, because they are screaming essentially from the rooftops that these things, that for their treatments are possible. Their lives can be lived, but now they're under threat, like every other patient, of having their access blocked. It is happening.
Jonathan Wilcox.
Are you speechless?
Well, it's another voice, it's another argument in the healthcare debate, and I agree with you. We have yet to have a serious conversation about healthcare in this country because it's been politicized. It's been, we've weaponized the conversation about healthcare. So if heaven forbid somebody were to bring up another idea, you are all of a sudden a liberal, a communist, a pinko, and all we've done is do nothing to solve any of the problems that still exist.
Well, fundamentally, you really hit it on the head. Look, I'm very critical of what ICER is doing and their approach, but I'll tell you something. I'll link arms with them. Let's break open the Budweiser, and we will sit with them as long as it takes, as often as we can, wherever they want. We can work together. I just think that this approach of simply cutting, and I think cutting and running, isn't going to work for the patients that we've seen. So look, anybody at the table, anytime, any conversation, everybody's got smarts, everybody's intelligent. There's a lot of smart people in this business. I just think they've frankly thrown up their hands and given up, and we've got to demand to do better and then resolve to do it together.
Jonathan Wilcox, that website one more time.
Patientsrising.org.
And you're back in January?
We'll be here in January. That will be the next time ICER's here to evaluate arthritis. You see, look, there's another example. They're going to say, hey, here are the medicines for arthritis. These are the ones we think are too expensive. We're going to be right back everywhere that they are going to be to challenge the patient interest. We're going to bring the patient voice and make sure it speaks up and it's heard. And I will see you in January, if not before.
Jonathan Wilcox, you're always welcome here on the show to talk about this and all other healthcare topics. So thanks for checking in.
I'll be back.
You got it. Jonathan Wilcox here, co-founder and policy director of